Hello all. Thank you, Anne-Marie, for the lovely welcome and introduction. So last time, I'm Maria Gardani. I'm a lecturer in clinical psychology in Edinburgh, and I'm an ex-member of the Glasgow University team. So I've recently migrated over the M80. Last time I spoke to an event was small. We were just actually saying that with my colleagues, Brian and Liam there. Last time we were here, I was here and speaking to an event of Head Injury Information Day. It was really small room, so it's great to see the event becoming bigger and bigger and seeing all of you here this morning. So today I will talk about the work that I'm passionate about and I do have a lot of experience, which is sleep, insomnia, and I do have a focus on people who've been affected by acquired brain injuries. Maybe the talk is a bit technical at times, but again, if you want to ask any questions at the end of the talk, please do that. And I'm also going to be here at the break, so you can come find me if you have any other questions. So, okay, that's the first slide. So what I will try to cover today is, again, what we know about sleep and primarily insomnia disorder after acquired brain injury, what people tell us about their experiences of having insomnia or having sleep difficulties after experiencing an acquired brain injury. And also, what can we do? What do we know from science, what we know for intervention, what we know for therapy that we can do to help people with their sleep problems after a brain injury? So I'm starting with this very busy slide, which really tries to capture, again, the different conditions that come under the umbrella term that we use to describe acquired brain injury. So we have injuries, accidents, can be anoxic episodes, could be head injury, strokes, and all these have, based on their location, the brain, they have different complications in the lives affected after the injuries. So this can result in migraines, loss of consciousness, memory problems, concentration, difficulties with everyday life, and also, quite importantly, mental health problems. People feel anxious, feel depressed. They really have to deal with their everyday lives after that. But what really is missing from the slides is what we see from research, the high prevalence, the high percentage of people experiencing sleep problems after an injury, after a brain injury. The reasons for that are a lot. I'm not going to go into that. Primarily, people normalize that having a sleep problem is expected. You do have an injury, you will not sleep well. But also what we know from research in all population, all groups, is that having a sleep problem, not sleeping well at night, means that your concentration is affected, your memory is affected, all that without having a brain injury. So imagine those who have a brain injury, imagine if you have one, how that has an additional effect in how you feel and how you deal with things the next day. So it has a cumulative effect. So more research needs to be done. So what we did is trying to find out, okay, so what do we know? How many people have insomnia, which is a specific disorder that presents with difficulty falling asleep, staying asleep, or waking up too early. So how many people have insomnia after they had a stroke? So we're trying to pull the evidence, as we say. So we're trying to pull the research together to try to see, okay, what is the percentage of people having insomnia disorder as defined by diagnostic manuals after having a stroke? And again, the research is really messy. That's a caveat, that's a disclaimer. It's not always defined well, it's not always been reported appropriately. But what we found is that about 30%, I don't know if I can use that here, this point. No, I don't have a pointer. So 30% roughly of people have insomnia that reaches a threshold for a disorder after having a stroke. And when we not define as strict the criteria for insomnia, we find a higher number. We find about 38 people have insomnia after experiencing a stroke. So these are high. About 1/3 of those who had a stroke will develop insomnia with all that contains. Did the same for mild traumatic brain injury. And again, the numbers are higher here. So if you compare these numbers with the general population, that usually you find that people have about 20% of those have insomnia, the numbers here show really high prevalence. For traumatic brain injury, mild traumatic brain injury, we see 27% of those will reach the threshold for diagnosis for insomnia, whereas 71, which is a whooping high number, we reach sleep difficulty and insomnia symptoms. Again, the caveat is that the research is messy, and a lot of the studies come from blast injuries, from war zones, which again makes it a bit more difficult. But again, still the numbers are high. So we do see high prevalence, a high percentage of people experiencing sleep problems after different brain injuries. So this is what research tell us. What people tell us, though, what people who had a brain injury, people who had a stroke tell us, how they experience these difficulties after having a stroke. And more importantly, what do they want? What do they want from their treatment? What is the preference for treatment? What is the preference for seeking, for having support? What do they want and what do they get? So we've done, this is work that's been conducted by my PhD student, Declan McLaren. So he interviewed 10 participants after experiencing a stroke. And that was a very long and deep-depth interviews that lasted from 50 to 90 minutes. So they were long and trying to get their sense of their experiences regarding their sleep difficulties after their stroke. And we use the analysis, which is interpretive phenomenological analysis, which is a way of trying to interpret the narrative of someone else, trying to see, like, okay, what does that mean? What their experiences mean for somebody after a stroke? How can we make sense of these, and how can we put them together and share them with the general public? How can we share them with physicians, clinicians, and other researchers? How can we make sense of their experiences? So it's interesting, and a lot of things came up. I mean, like the narratives and the reports were really interesting, but also some of them were really, really terrifying. People expressed how difficult it was for them to be in hospital settings primarily, going through surgery, going through ICU, which is like blast, like lights all through the time, and that was very difficult to stay there and like sleep, so that was really affecting their sleep and how they were feeling. They found that the words were not really good. They found that it was like, again, like it was very difficult to make sense of the words, make sense of the environment, so that came quite heavily. But when they spoke about their sleep difficulties and what really kept them awake at night, most of the time people, and a lot of times, talked about their fear of another stroke, how they would feel about having another stroke. It's no surprise, like a lot of strokes happening early times in the morning. A lot of people were lucky not to be alone at that time, so they found somebody to actually take them to hospital, have fast treatment, and that really is very helpful. But again, some people say that they really don't want to fall asleep, because what if that happens again? What if they're not lucky again? What will happen? So a lot of people say that they're not sleeping in the beds, they may be sleeping in their couches, or they try to avoid sleep altogether because of that. And here are some quotes from that. And again, as you can imagine, that really has an effect on anxiety, feeling anxious, feeling stressed. And again, they're overthinking that, they're worried about that, and we know that insomnia is really embedded in worry. It's a psychophysiological disorder, but again, the main issue is psychology. It's trying to worry, they worry too much. They're anxious, they're racing minds, so they cannot really switch off their minds about difficulties and how they will deal and cope with their lives. So that came quite a lot as well. And when we asked them about what they want from their treatment, what would be the preference, one thing that came equivocally was that they don't want sleep medication. They say that sleep is natural, they should be able to fall asleep, they don't want to take medication, they feel that they're in a lot of medication already. So they really don't want to have like another pill to help them get to sleep. So this is quite interesting to see, because this is primarily, most of the cases, what is really only available for a lot of people with insomnia, not only after acquired brain injuries, but for more people, where we know that there's some interventions that can actually help. So what we can do, this is a very small study that we've done in Headway quite a long time ago. I went back and looked at the data, and we're just about to publish that. It's been submitted. And that's like a case series design, so we only have 6 participants, 5 men. 3 of them had traumatic brain injury, an injury with high severity. And the 3 were a stroke, a tumor, and an anoxic episode. So what we're trying to implement here is like a very brief intervention, just again like that based on the cognitive behavioral therapy for insomnia, but primarily focusing on only the behavioral elements, which is stimulus control and sleep restriction. Primarily trying to understand when you're feeling sleepy, you have to go to bed, and when you're not feeling sleepy, you have to leave. And trying to really change your habits and lifestyle to fit you better sleep, to have like a more conducive sleep environment. So it comprises of 4 sessions. The sessions were on a Headway, so pretty much like during the club time, the session that people were there. And the first session, that was like in small groups of 2. And we had like booster sessions, pretty much trying to get people to come more into terms and make sure that if they had any problems with intervention, if they had any problems with their guidelines or what we're suggesting, we can actually problem solve that. And all people who took part and stayed in the treatment, because again, it's not easy, it's not for all, but all 6 of them who stayed in the intervention had better sleep quality subjectively as they experienced it following that. And this is one part, and I will not present the data because again, like it's 6 people, so it's not really going to see any effect size or anything. But this is one participant here. That was a 70-year-old man that experienced a tumor. And although he reported that his sleep quality was really good before his surgery, but really declined after, alongside his quality of life. So the first slide you see here is the wake time. So this is how he was quite a lot of the night he was spending that awake. So he found that most of the night he was awake and he was not easy for him to fall asleep. This period is the intervention period, as you see, between BBT1 and BBT, between the first 2 brackets. I wish I had a pointer. So you see that how his wake time really drops substantially, and that effect stays in the follow-up period. So these skills, this idea on how to manage his sleep quality changed the way that he would approach his sleep patterns and what he would do in his lifestyle. So that stayed for a long time, including the follow-up times. The second graph here shows the sleep efficiency, which is an indicator of how good the quality of his sleep was. And we can see how that improves, and this is in the right direction. So we see that this is getting higher over the period of the treatment and stays higher when he's in follow-up. And also the sleep quality, subjectively, how he rates his sleep every morning that he wakes up. But what's interesting is that these people also experience an improvement in anxiety and depression after improving their sleep. So they were really feeling a lot better, the mood improved. And that is quite an important aftermath of improving your sleep. And this is something that we know. If we improve our sleep, usually the lifestyle changes will improve our depression, improve our mood as an after effect. In a different study, again, like in the small study, we use mindful music listening. Again, like here, the instructions were a bit easier, a bit more, it was not as strict. People didn't have to leave their beds. People didn't have to do like more elaborate things in the lifestyle. They were told, again, there was like a lot of psychoeducation, understand their sleep, understand what will improve their sleep, understand how to get light and exercise at different times of the day. But the intervention was primarily listening mindfully, actively listening to music for 30 minutes before going to sleep or until falling asleep. And the instructions were actively music listening, again, like using this music listening mindfully. So the idea that you are there, you're present. So the instructions were like listen to the music, and if you feel that your mind is racing, you start thinking something else, get it back here and continue listening to the music. Most of the people in the study listen to classical music, which is quite conducive in this like feeling of calmness and relaxation. But they could listen to something else if they wanted to. The idea is that they just concentrate on something else and you just be actively there. So it's a very simple paradigm, and this is, again, that study led by Satu Baylan, which she saw in her music listening study that was, again, for anxiety and depression, that also people reported differences in sleep. So this is what we did here. We just focused on the sleep element. And what did we find? We find that 4 people out of the 6, they had no sleep difficulties after this like 4 weeks of music listening, and that effect stayed for a long time. So that was there, stayed in the follow-up period. So we find that the effect was really long-term lasting, but also we see changes in anxiety and depression and psychometric tools that are rich in diagnostic criteria. So music listening actually had an effect not only in their sleep, but also a knockout effect on their depression and anxiety. So it's very interesting and very promising results in that effect, especially as people find music listening quite a pleasant way of engaging, and they find it is not cumbersome, they find it's quite easy for them, it's quite pleasant to engage to. It's not for all, but still, a lot of people find it very good. So, coming to the end of my talk. So what we know so far, we know that people after acquired brain injuries, they have high prevalence than the general population of insomnia and sleep difficulties. And most of the studies actually show that. We don't know why. Could be the location of the injury, could be the environmental changes, could be the hospitalization, but in most cases we think it's the change in this, like the lifestyle and change like the lives that really impacts their worry and rumination and thinking about things that has an effect. We do have to understand what works for sleep problems after acquired brain injury, but primarily we have to do this by listening to people who've been affected. So we really need to listen to more people, and we know that improving sleep can have a knockout effect on mood, can have a knockout effect in depression. So sleep can be like a good conduit to not only tackle the sleep difficulties that a lot of people are experiencing after acquired brain injury, but also can be the pathway to change, have an improved effect on depression and anxiety. So we hope that we really need to screen, that there's a high need of education, everybody be involved with people in the ward, in the acute setting, the wards and rehabilitation centers, to really think and consider sleep difficulties, and how this may have a problem, may play a role in how people are feeling, how people are experiencing their lives, how people are responding, how people are responding to treatment, and how people are ready for even a therapy session. So sleep has to come there routinely. People have to learn more. People who are working, those affected by acquired brain injury, have to learn more about sleep and understand sleep and the importance of sleep. And also we have to listen to people. We have to understand what works and what doesn't work, what people want and what people need, and how that can be different. And what can be a good way of using the resources and funding, which is really scarce at the time. So how can we really make sure that the funding goes to whatever really works, and how people are really feel that this is really good for their lives and can improve their lives. And sometimes can be larger trials as well, just to see the findings, because that's the only way we can actually change the guidelines. This is the only way we can actually make an effect. So most of the work has been supported by Stroke Association that will work together, and their partners in Declan's PhD, and also the Scottish Graduate School of Social Science and NHS Greater Glasgow and Clyde. Thank you. I'm happy to take questions. There's one here, Anne-Marie. Sorry, I think we got Anne-Marie.
Hands up to remind me. Right, I'll start at the back and work my way forward.
Hi there, thanks for your talk. I wanted to ask, considering the research you've done, you're speaking about a small sample, But the music therapy impact seemed to really work, although it's a small sample. And I was wondering if the difficulties people face following an ABI with sleeping might be a consequence of central executive function and an inability to shift from beta waves to alpha waves as we essentially daydream ourselves into sleep normally. And in thinking that music therapy probably induces alpha waves because you daydream away with the music, is there any intention to expand research in that field?
We're really hoping to do like a larger trial on the data, but again, probably we will be including polysomnography, ambulatory polysomnography, but we're in the process of actually applying for funding at the moment. But yes, this is exactly what we should be looking at, but not at the moment.
Sorry, that being the case then, is there a requirement, do you need access to more patients with ABI to study their sleep? That's what I'm asking.
For
research?
Yes, of course. Of course. This is this is a single case experimental design, which is a very tight protocol design that gives you very good findings, which then you can have grounds to move forward and apply for larger funding studies. So we have actigraphy data. We have a lot of data from this sample, even though small, it's quite rich in the data we have gathered over the 7-week period. So hopefully we'll be able to apply for a larger scale, like a larger study, yes.
Okay, thank you.
Thank you. I see another hand. Yeah.
Thank you for that talk, Maria. It was really interesting. It's more of a kind of observation from the inpatient point of view.
Yeah.
As clinicians, we actively disturb our patients' sleeps because we need to. We have to, check on people. We have to do bed rail checks. We have to support with incontinence and things overnight. So do we feed into the sleep disturbances and the difficulty in sleep patterns in clinicians, and how do we manage that? Because we know our patients are tired when they come to rehab in the morning because they haven't slept.
This is an excellent point. I think I tried to. I didn't go into that when I was talking, but again, there's a few things that need to be done during the night, and again, hopefully, I know that Brian is talking next about technology, but hopefully, technology at some point will be able to support this overnight engagement with patients, because again, we need to make sure that this is something. Hopefully, we can be moving to that direction. But no, it's I know that everybody has to work, and I do appreciate that. But again, hopefully we will try to find, and this is something that we have to work together, clinicians, researchers, and patients, trying to find ways that we can make sure that the night is the time of restoration and feeling better.
Thank you. Oh, not far to walk this time.
Hi, thank you for the information. My daughter's had a acquired brain injury, but she also struggled with sleep prior to the injury. And so I've done several bits of research on how to assist. The action of taking, say, melatonin to assist with the sleep, I've read that you can take the melatonin for a short period of time, but after that it doesn't really have much input. We also read, she was planning to go out and spend an evening away with a friend last week, and in the end she said, no, actually I can't, I have to come home to my own room. So we've created an environment where she feels that that's where she wants to sleep. So on her bed she's got an electric blanket because she's always cold. The other thing that we've utilized was red light, the LED red lighting, which apparently said that that also increases melatonin production while you're sleeping, but she has everything else is darkened. It's just the red light in the room. She doesn't take any medication per se for it, but she does find that her sleep is very quickly interrupted. And I also understand that another thing that bothered her quite a bit in the beginning after she was discharged was that she said she didn't dream anymore. And now that she's we're reducing one of the other medications that she's on, and she's having a bit of bizarre dreams, which obviously it shows how sensitive the brain is to any form of medication. How can one make that environment? I mean, it is a sleep habit that you were talking about, but it makes it very difficult for the patient, the client, to actually live a relatively normal life. Have you got any suggestions or any experience with how we could assist in that?
Thank you for the question. It's again, like the way you present it, it's not easy, it's complex, it's a lot of things that come into play, and a lot of people like yourself try different things to see what helps. In most of the cases, what we can do is guide people in changing things little by little, because if you change a lot of things at the same time, you don't know what works, and probably you're overwhelmed. So changing things smaller and little by little probably has a better effect. And then you can see what things change. But what we have to keep in mind is that sleep for everyone is not always good. We will have 1 or 2 nights that perhaps we're not sleeping well. It's how you feel in the morning and how you can actually function and be well. So I think their expectations have to be more realistic on how good our sleep can be. But also we have to try things slowly. And it's good if we have some guidance, someone that we can really bounce ideas off, and somebody we can talk about things. Melatonin is good, but it's not really considered as the source for everything to help sleep. And there's a lot of considerations and concerns about over-the-counter melatonin. Again, this, it's not available here, but in the States, they found that the doses are the range is really high. So one has to be quite careful on that as well. So I don't know if that helps, but I'm happy to talk more about it in the break, if that's useful.
So I've got time for one more question, and I think I have to go to this front table because this gentleman's had his hand up.
Thank you very much. I just want to say that there is another side to it. Yeah. I had brain damage from a motorcycle accident, and my problem was that I was sleeping all the time, which meant all the medical people couldn't help me in any way. But there is an amazing gentleman who will be very angry at me just now. That gentleman over there, Brian O'Neill, neurosurgeon, who said to me one day, he said, "Guido, there is a drug in America that helps you because 1/2 inch above your ear is a lobe that stores melanzone from sunlight. Yours can't store it, so you think it's sleepy time all the time. Are you prepared to take it?" That's the only reason I'm walking. I'm alive because of that gentleman there. Give him a round of applause, please. Sorry, Brian. I've got to do it every time because I love you.
Thank you, and thanks very much for your questions. Could you please put your hands together for Maria? Thank you.
Thank you.